Because the inferior articular facet of C1 slopes superior oblique, that we just talked about now. The top articular facet that articulates with the condyle of the occiput now, instead of sloping like this, slopes like this, so it goes inferior oblique. So, when we treat fixations of C1 to occiput, the only thing that's going to change from what I've just shown you now is one thing, the line of drive. Instead of being superior oblique, it's going to be inferior oblique to conform to the architecture of the C1 to occiput facet. Okay? So, it's very easy to do that. So, and then everything else is the same. Okay? For the rotary technique, we're still going to have an index finger contact on the posterior arch. For the lateral flexion technique, we're still going to have the knuckle contact on TVP of C1. The only thing that changes is we're not going to be thrusting in this direction anymore. We're going to be thrusting in this direction. Then everything else is exactly the same. Okay? Easy. Initially starts out looking complicated, but there's just a couple of things that change. So, C1, oh, we better do the motion palpation, just refresh that for you. So we'll come over here. Okay. Yeah, why don't you face out that way? Okay, remember the motion palpation for C1 to occiput? We're going to find the transverse process of C1. And then remember we moved forward into the space between the transverse process and the ramus of the mandible. And in that small space, we can test for three things. We can test for flexion, extension, and rotation. Again, limiting the movement of the head to 15 or 20 degrees. Remember, on flexion, that small anterior space will get smaller. On extension, it gets larger. And on rotation away from the side that we're palpating, it gets larger. Okay? So smaller, larger, larger, if everything is normal. Okay? Any variant of that indicates a fixation pattern between C1 and occiput. For lateral flexion, remember, then we move backward into the space between the TVP and the mastoid. So, we're pulling back into that small posterior space, and then we're going to laterally flex away from the side that we're testing, and that space should open if there's normal movement on lateral flexion between C1 and occiput. Okay? So, when you're looking for that anterior space, just come in and find the transverse process, and then move your palpating finger forward so that your fingernail is touching the posterior aspect of the ramus of the mandible. And that will automatically put your finger in the anterior space. And then if you pull back so that the palmar surface of your finger is pushing against the mastoid, then that will put the tip of your finger in the posterior space. Okay? And then the posterior space will laterally flex away, and that space should get larger if we have normal movement of C1 to occiput. We all okay with the motion palpation? Okay, so patient back on their back. We'll do the rotation first, okay? So, we're going to bring the patient into flexion. We're going to reach way over, and we're going to slide back onto the posterior arch. Now, if you take a look at my arms, but especially my right arm, which is the contact arm, you will see that it's already pointing downward, and that's the way we want it to stay. So the way we do that is the doctor stays at the head of the table. So when we're doing C1 to occiput corrections, the doctor doesn't come around to the side of the table anymore, because as soon as I do, watch what happens to my right arm. See, my body pushes my arm into the superior oblique direction. But if I stay here, my arm is already in the position that I want it to be in. So the doctor stays at the head of the table for C1 to occiput techniques, okay? So, those of you who are in the front row here, you can probably see this line on the carpet across the stage. So that's the line that I have to stay behind, okay? If I do that, this arm will be in the proper position, okay? So if you don't have the convenience of a line, you can draw an imaginary line from the tip of the patient's nose outward, okay? So the doctor's hips and legs and feet have to stay above that line. You can lean over it like this if you want, but the hips and the legs and the feet have to stay above that line. If you do that, this arm will always be in the correct position for C1 to occiput. Okay, so we're coming up, taking out the skin slack, sliding onto the posterior arch, supporting the head. Now, the head is flexed. We're going to do a little bit of lateral flexion. Get down low. Rotate the head away. See, my arm is still in the inferior oblique direction. And then once I've taken out all the skin slack, I want you to tip the patient's chin down like that. So you're going to push the chin down this way. That just helps to gap this area and opens it up so that at this point, once I've tucked the chin in, I can do a rotary thrust like that, okay? And my arm is pointing in the direction that I want it to be in because I stayed at the head of the table. So basically, the only thing that changes for C1 to occiput is the line of drive. And the way we maintain that is for the doctor to stay at the head of the table, do the rotation, tuck the chin down a bit, and then I'm thrusting in this direction. Okay? So if you remember how to do C1 to C2, the only thing you have to tell yourself is for C1 to occiput, stay at the head of the table, rotate the head, tuck the chin in, and thrust down towards the opposite shoulder. Okay? Same thing applies for lateral flexion. It's still the knuckle contact on the TVP of C1, but now it's a lateral push in the inferior direction as opposed to the superior direction. So same rules, flex, turn the fixated side up. Let's get our knuckle contact in there nice and snug. Rotate the head back, spin the hand around. Maintain the flexion. Little bit of rotation. Get down low, stay at the head of the table. Pull the head over into lateral flexion, and I'm going to thrust with a short, fast push across towards the opposite shoulder. Okay? So it's a push this way for C1 to occiput. It's a push this way for C1 to C2. Okay? So whenever we're dealing with occiput, the thrust has to be down that way. And we accomplish that by staying at the head of the table. So the only thing that changes with C1 to occiput is the line of drive. And the way we do that is to keep the doctor at the head of the table. Contact points are all exactly the same. Okay? Any questions on C1 to occiput? Okay, lastly, occiput to C1. Okay, now we have to test how the occiput with its condyles articulating with the superior facet of C1 are moving independently. Okay, so we'll have you sit up and the motion palpation again. Remember for occiput to C1, we're taking a middle finger and a ring finger contact on the posterior aspect of the mastoid. I'll show this on both sides so both sides of the room can see. And to test rotation, we're going to rotate the head. I'm testing the right side, so we're going to rotate the head to the left as far as it will go. And then I challenge the spine, the mastoid process with a little push. I'm just giving it a little push like that. Okay, over here, contact the posterior aspect of the mastoid, turn the head to the right as far as I can, and then I challenge the mastoid with a little push like that, okay? And if we have normal movement on rotation of occiput to C1, that little challenge should be soft and springy. Okay? If it's hard, stiff, resistant, then you've got a rotational fixation of occiput to C1, okay? And for lateral flexion, it's almost the same. Now for lateral flexion, what we're going to do, if this is the mastoid, for rotation, we palpated back here. For lateral flexion, we're just going to move over to the side. So we're going to hold the patient's head in sort of a caliper grip. With these two fingers, I'm going to go onto the side of the mastoid process. I'm going to laterally flex the head over as far as I can, and then the challenge test is a little flick of the wrist like that. So we're going to be rocking the occiput in a sideways fashion. So I come over as far as I can, and then with my right hand, I'm just going to challenge the mastoid like that. And again, we're looking for soft, spongy, non-resistant end feel, okay? For the left side, so I'm going to palpate on the side of the mastoid process. I'm going to laterally flex the head into the side that I'm testing, and then at the end range, I'm just going to do a little flick of the wrist like that to rock the occiput, and again, soft and spongy end feel. If we're getting a hard, resistant feeling, then we've got a lateral flexion fixation of occiput to C1. Okay, so the corrective procedures. Put the patient back down on the back. So for rotation, what we're going to do is a soft pisiform contact on the posterior aspect of the mastoid process. Okay? Remember when we were doing cross bilaterals in the thoracic spine? You guys are all experts in that now. I wanted you to have a real sharp, pointy contact on the transverse process and then the thrust. With this one, not so sharp. I want it to be more of a soft, padded contact. So you'll see when we take the contact, instead of cupping my hand like that, it's going to be flatter so that this area is more cushioned, okay? With the non-adjusting hand, so we're going to pretend the problem's on the right side here. So my left hand will be the non-adjusting hand. It has two roles to perform. It helps to support the head, but these three fingers, for index finger, middle finger, ring finger, are going to wrap themselves around the upper cervical vertebra, because for this technique, when we do the thrust, we really only want to move the occiput and the occipital condyles, and we want to eliminate as much rotation in the cervical spine as possible. So if we use these three fingers to sort of wrap themselves around the upper cervical spine, it will help to lock C1, 2, and 3 so that the occiput is free to move when we put the thrust in, okay? So this hand will help to elevate the head, and then instead of being flat like that, the fingers are going to curl like that around the C-spine to lock it. So we're going to bring the head into some flexion. Then this hand, the fingers get wrapped around the upper C-spine. So they're actually sort of putting a squeeze on the upper cervical spine. Then the palm of my hand and the heel of my hand helps to keep the head flexed like this, okay? Then I'm going to turn the head to the left. So we have to position the patient so that the fixated side is up. So we're turning like this. We tested the right side has to be up. The doctor comes around to the side of the table, places the soft pisiform on the mastoid, and just let your fingers go across the patient's face like that, okay? So you basically then have the patient's head like this, and you've got the soft pisiform on the mastoid, and we're going to be thrusting in the direction of your fingers. You're going to be thrusting across the patient's face like that.